Any advice given on Unity FM relating to health conditions must be verified by your doctor. General diet and physical and spiritual well-being is discussed on shows, but this is general only. If you have any medical condition or need medical advice, please consult a doctor.
Hello and Assalamu alaikum. This is Muhammed Ali Bazir. We have an interesting topic in relating to thalassemia and how it affects people. We have two lovely guests from SCAT Centre in Birmingham City Hospital and Thalasemia Society.
Hello, I'm Liz Green. I'm the lead nurse at the SCAT Centre. The SCAT Centre stands for Sickle Cell and Thalassemia Centre, and we're the regional specialist centre based at City Hospital in Birmingham.
Hello, I'm Elaine Miller from the UK Thalassemia Society. We're the only national charity set up specifically to support people and families affected by thalassemia in the UK.
Also, just to remind our listeners, any information that we provide through Unity FM, it's in general, and you need to speak to your specialist according to your needs. Our next question, which is probably one of the most important ones, is there a cure?
Well, yes, there is, but it's not as simple as saying, yes, there is a cure. The cure is a bone marrow transplant. Bone marrow, the part of our bones called bone marrow is what makes the red blood cells. So if you can replace somebody's bone marrow, then they can make red blood cells that work properly. However, saying it like that makes it sound really simple and really easy. It's not simple and it's not easy. You have to find somebody who's a very, very precise match to you to donate that bone marrow. And it's also a tricky and difficult procedure. So it's not something that's undertaken without a lot of discussion with the doctors and the parents, because generally this is done when people are children. There's a lot of discussion around whether this is the right way forward, because as we've sort of highlighted already, in this country, if you have your blood transfusion and take your medication, you can live a normal and full life. So you might not need a bone marrow transplant.
And not everybody would be suitable either.
Totally. You're totally correct that not everybody would be suitable, and not everybody you would find a match. You're more likely to find a match from somebody who is from your family, but some people find matches and some people don't.
And there's other issues as well. For example, somebody who needs a heart transplant or somebody who needs a kidney transplant, their body might not be suited for it either. Yeah. So it's the same with bone marrow transplant.
Totally.
I think one issue that I would like to get across about bone marrow transplant is that people who've had bone marrow transplants are often subfertile or infertile. If your child's 2 or 3, it's very difficult to think in the future to them actually becoming parents. But nowadays, most people who've got thalassemia major are able to have healthy children of their own. It's important to recognise that if the child's got thalassemia major and they're getting a bone marrow transplant, it could cause infertility in the future. It may not seem, as I say, it may not seem a problem when they're small children, but we have now got people contacting the society who are in their 20s and 30s who've had bone marrow transplants when they were children and have been left infertile. There's very little that you can do about that.
And this infertility is caused by the very high dose chemotherapy that you have to wipe out your own bone marrow for the bone marrow to be replaced from somebody else.
That's quite important to know before you go ahead with anything like
Definitely.
that. How can anybody prevent thalassemia to begin with?
Well, we can't really prevent it, but we can get tested and we can understand our chances of having a child with thalassemia. Okay? So if you carry it, you can't... if you're just a carrier, you're not going to be unwell at all. But in terms of prevention, what you could prevent if you chose to is having a child who has thalassemia. If you're having a marriage within the family, cousins for example, it can be more likely to have a child with thalassemia because our genes, which are molecules that dictate the characteristics and the traits that we have and that we inherit from our parents, so might make us tall or good at maths or have curly hair, you're more likely to have cousins who both have curly hair or both tall or both good at maths. In the same vein, you're more likely to, if one cousin carries thalassemia, for another cousin to carry thalassemia. So it does need to be thought about in the context of families where arranged marriages and marriages within cousins are common.
But that's not necessarily just cousins. That could be with anybody that they get married to.
Actually, most people who've got children with thalassemia are not married to their cousins. Mm-hmm. It runs in families, like anything that runs in families. So if you know that you've got thalassemia within your family, If you marry within your family, then yes, you've got a higher incidence, a higher possibility of marrying somebody who's got also carrying thalassemia. But having said that, it's a mistake to assume that you're safe from thalassemia. If you do, anybody could be a carrier. So the vital thing to remember is have the test, go to the GP, ask to be tested and screened for thalassemia before you have children, whether you marry within the family or out of the family. Nobody, that it's not an issue to us. It's just a question of getting tested so that you either way.
You can't look at somebody and tell whether they carry thalassemia or not. We talked about the ethnic groups that are more likely to be affected by thalassemia, but it's wise to get tested because of the way that we all live these days. It's not necessarily just those ethnic groups that are affected. I would advise anybody having a baby to be tested for unusual haemoglobins and their partners.
We get many calls to the society of people who've just found out that they're carriers, and they will commonly say, "Oh, I can't believe this. I'm British. I don't know anybody in my ancestry that's." But the British are a mixed up
bunch,
race anyway. The
Yeah.
Romans were here. Thalassemia is common in southern Europe.
Yeah.
So there are plenty of people who are walking around as carriers. And as we said earlier, carriers are perfectly healthy. So there are many people who are born, live and die as carriers, and they never even find out. They just might find out through a random blood test at some point. But what happens is every pregnant woman is tested. We do have a screening program, which we mentioned before. So we're getting more and more people diagnosed now as carriers than ever before. What we need to do is talk about it and raise awareness of it, because there's still quite a lot of reluctance to talk about this issue of people in the family who carry thalassemia. People like to keep things very private, and that's understandable. But this is something that can have a massive effect on your family in the future. And if you know you're a carrier, and you get married and you marry another carrier, that potentially that's going to have an effect on your family. If your child or some of your children have got thalassemia major, you can plan for that. You can actually have a test in pregnancy, which will tell you if the baby's affected.
Right, I mean, it's important that you brought that up regarding somebody who's marrying in the family or outside the family. It's like some of the other illnesses, the risk is more if it is from the family, but that doesn't necessarily mean that's the only way you're going to get it.
Oh, yeah,
it's just a possibility that it's going to be probably more likely that you might get.
But as I said, the test is available to anybody. Anybody can. It's a very simple blood test. And you can have that before you get married, before you have your child, so that at the very least you can learn about what thalassemia is. What happens at the moment is that people find out when they're expecting their first baby, and that's the worst possible time to find out. You're just expecting and to get this sort of awful news. And to be told, well, we don't know the baby. There's a 25% chance your baby may have this condition and have to have blood transfusions. It's a terrible shock to people. At least if you find out when there isn't the pressure of a baby already on the way, you can talk about it. You can discuss it with your wife or your husband. You can discuss it with your other family members. You can learn about what thalassemia is. Anything's more frightening if you don't know about it. And, people have never heard of thalassemia. Finding out that your unborn child might be affected by this scary sounding condition is very traumatic. And we, unfortunately, at the society, we get lots of phone calls from young women who are in tears because they're pregnant and they've just been told, that their baby may have thalassemia. It's much better to find out before you have children, so that you can learn about it, and you can learn that it's not a fatal condition. Some people find out and they only have a limited amount of information, so they think it sounds like leukemia, it sounds like something that's fatal, And it's important
when you're in that vulnerable, just pregnant stage, you're so emotional anyway, and to process any kind of extra information about your unborn child is so difficult and traumatic. I would add that with the universal screening programme now, because we tell the parents of their babies that their babies are carriers, that hopefully then the parents have got the chance of bringing their child up with an open and honest conversation about the fact that they carry thalassemia or any other condition, that they can then talk about it and know about it before they decide to have children.
Somebody who's from those sort of ethnic backgrounds and they are marrying somebody in the family, or even if they're not marrying somebody in the family, it's better to have that discussion beforehand if they already know that they are a carrier. It makes it a lot easier than coming up at a much later stage. How you said, it's really difficult trying to tell somebody that the child
talk
has
about it with
thalassemia.
your family, talk about it with your partner, talk about it with healthcare professionals. No healthcare professional is going to judge you, or they're just going to offer you facts and allow you to make the decision that's right for you and your family.
And it's the same thing with your partner as well, that it's important to discuss with them beforehand.
Openness and honesty about it is all we're sort of asking from people. It's difficult to bring this kind of matter up sometimes with the person that you're thinking about marrying,
because you don't know how
it
they're
can
going to
be
react.
Exactly.
when do you say it? When do you talk about it? But then
It's not really first date
no,
material, is
it's
it?
not.
No, of course, and it's the same. I mean, but at the same time, it is important. But
Yeah, I think once you're going down the line of marriage, and if marriage is then going to follow children, it's something that needs discussing, isn't it?
yeah, because once you're compatible, then that is another aspect of being compatible as well. Doesn't mean that if they have thalassemia, it's the end of the world.
No.
There are precautions that you can take to make sure that your kids don't have thalassemia.
If that's what you want to do, there are those choices you can make. You can, indeed, as I said, that you can have a test during pregnancy. You can have it quite early, in about 10 weeks of pregnancy, that will tell you if the baby's affected. Not everybody will choose to have that test, obviously. That's a personal matter.
Of course.
But it is available if people want to do it.
Let's say, for example, somebody from the couples, both are thalassemia. Are there ways that they could prevent so that kids don't have thalassemia beforehand?
You mean if they've both got major?
Major.
Oh, no. If they have
So
the child biologically.
If we have
But are there ways...
No, we have 2 genes each. So in somebody who's a carrier, they'll have their normal, although I don't really like the word normal, their normal gene and their beta thalassemia gene. In somebody who's got beta thalassemia, they've inherited their 2 genes from people who carried it, and they've inherited the beta thalassemia. So the only genes they possess are beta thalassemia genes. So those are the only genes that they can pass on. So if a person with beta thalassemia major had a child with another person with beta thalassemia major, they could only have children who had beta thalassemia major. There's no way of preventing that.
You can only do it by having a donated egg or donated sperm.
Okay.
That's the only way you could end up with a child without
But if somebody
the
who
condition.
has beta thalassemia or major and the other person is only a carrier,
Then it's 50%.
Then it's 50%. So you still have got that risk.
Oh yes, if you're a carrier, if every carrier has a 50% of passing on the gene, the unusual gene to the child. So if you've got one partner who's got major, they don't have any regular genes to pass on. They can only pass on an unusual gene. So then you're down to the 50% odds from the carrier partner.
I think that's one of the
pass
biggest concerns for parents and parents to be. So it's really important that you speak to your specialist regarding that, and you go by.
We all carry, every one of us carries these unusual genes. All of us carry unusual genes of all kinds. Usually they don't cause a problem, but occasionally they do. It's nothing to be ashamed of. It's nothing, it's nothing you can control. It's nothing to feel guilty about.
So it's more important to just be aware of these things.
Yeah. And it's the same sort of thing as, needs a bit more care and attention. The same sort of thing as being good or bad at maths. Okay. Just a little bit more care and attention. I think when we were just talking, though, about the inheritance, it would just be worth mentioning. So if you've got a patient who has got beta thalassemia major, so they can only pass on beta thalassemia. If they have a child with somebody without beta thalassemia, it just means that all their children will carry, so have the ability to pass on to their children.
Are there any other medical conditions that they could be caused related to?
Yeah, there is. And as we keep saying, as a bit of a theme throughout this discussion, that if you take your medications, then you can live a long, healthy life. Most of the other medical conditions associated with thalassemia are related to when patients get a build-up of iron in their body. So every blood transfusion, we give patients extra iron. There's nothing we can do about that. That's why we give you medications to help your body expel that iron. When you don't take those medications, that's when the iron builds up. And it's this iron that is really toxic to your body. It can cause problems with your heart, with your liver, and it can also cause problems with your endocrine glands. What's an endocrine gland? An endocrine gland, there are all sorts of different glands in your body that are responsible for things like stopping you getting diabetes, your thyroid functioning normally, making sure you grow properly, making sure you develop secondary sexual characteristics properly. So yes, you can develop other conditions, and that can make the management of your thalassemia a lot more difficult. But if you take your medications, there's no reason why you should develop these other conditions.
So it's really important to our listeners that they make sure they follow the advice of the doctor.
Yes, iron overload medication. There are 3 different treatments for iron overload, 3 different medicines that are used alone or together with each other. It's absolutely essential, I can't stress this enough, that if you've got thalassemia, you work with your doctor to find a regime that suits you, that you can take, that you can stick to, and you can take that medicine exactly as your doctor tells you to. They will all 3 of them will work, but you've got to take them the right way. You can't skip them. You can't. It's so essential, as Liz said earlier. You don't feel worse if you don't take your medicine, but your body, you may not know it, but your body knows it. That iron will be building up inside, bit by bit, in your heart, in your liver. You won't know about it maybe until you've got to a point where you've got severe problems. So the iron overload medication that all thalassemia patients take is just as essential a part of keeping them alive and healthy as the blood transfusions are.
Yeah, I'd agree. And as a nurse, I think I'm fairly approachable. So talk to me, tell me what you struggle with, and we can get a plan together. If you've got something about your lifestyle that means taking your tablets is tricky on certain days of the week or certain months of the year, tell us and we can work a plan. If you don't tell us, we can't offer you solutions. And I think one of the things I would talk about as well, when we're talking about individual differences, one of the things that comes up with our patient groups is at Ramadan, and what can they do about fasting? Talk to your doctors and nurses about it. There are ways, if you want to fast, that we can support you to do that. We can talk about your medications. It might be that you choose not to fast, and that is okay. But if you've got medications and a way that we can work with you so that you can fast, we will do that.
And of course, if they, like you just said, if they can't fast for any reason, and they have got the exemptions according to their religious belief, also speak to your mosque and your sheikhs.
Yeah, and that's fine. Just be honest with us. I'm not Muslim, so you might need to tell me things about the Muslim faith, but you tell me things about the Muslim faith and I'll tell you things about medication and the way that hospitals work, and together that's how we get a good plan. I don't know everything, but if you tell me stuff, it can help me and you develop a plan together. Of course.
What is a typical day for... In fact, going back to health-related, other conditions relating to thalassemia, you mentioned about having iron overload treatment. Now, somebody who's anemic and somebody who has thalassemia, generally, if somebody who's anemic, they give them an iron injection. But for somebody who's got thalassemia,
it is
they're not supposed to have iron.
No. Totally different. And it's one of the things that you need to be an expert in. If you've got thalassemia, you need to remember that you need blood transfusions, not iron. Because lots of GPs do know about thalassemia, but there are an awful lot of GPs who don't know about thalassemia. So when the patient talks or when they take a blood test, their initial inclination will be to give that patient iron. So know that you've got thalassemia and know that iron is not something that you need, and that a GP or another doctor, because you might go into a hospital and need another doctor for anything else, make sure that that doctor knows that you have thalassemia and that you know that you have a specialist that they must talk to.
Okay.
I think, can we mention also carriers? Because carriers of thalassemia, although they're not ill, they will often have a low hemoglobin reading, which is normal for them. It's completely normal for them. And what can happen is that they get given iron tablets because of this. Now, if they're actually iron deficient, that's not a problem, because you know there are many reasons why you can become iron deficient. But if it's just simply the fact that they're a carrier, it won't do them any good at all to take iron. And
our bodies can adjust quite nicely to just having a slightly lower than usual hemoglobin. Our bodies can cope okay, and in carrier status, that's what happens.
So if you need iron, like if you're a pregnant woman, for example, then you need extra iron just like any other pregnant woman. But if you're a carrier of thalassemia, you need a test called a serum ferritin test, which is what will actually tell you if you need iron or not just a simple hemoglobin test.
So are there any side effects with these other medications that people take?
The medications for iron overload? Yeah, I mean, there can be. It would take me a long time to discuss them now. That's not to say that there's a lot of side effects, but talk to your doctors. Some medications work better for some people, some medications work better for other people. There's options. As Elaine said, there's 3 types. So we can work. There's a medication that will suit everybody. They're not massive side effects. A lot of the side effects, if they do occur, can wear off, so people get used to the medication. They don't experience the side effects anymore. But if the side effects are bad, there are other options.
So basically, if you're on transfusion, the side effect is you could get too much iron.
Yeah.
And that could be the same with beta thalassemia. But if you're taking iron overload, that covers that side. Well, I think...
if you take any of the chelation medications, so you may hear people, if you know somebody with thalassemia, talk about medications called Desferal or Exjade or Deferoprone. You know, those are some of the words that you might hear. But if you take those, then there's no reason why you can't live a long and productive life.
So, like you said, speak to your specialist and see.
Yeah.
You can have a normal, healthy life according to your beliefs and religion. It's just that it's best to discuss it.
It's about working together. You know, no doctor or nurse is going to understand the intricacies of every single religion. So come and talk to us. Be open and honest with us, and we'll be open and honest with you about what will work with what you want to do.
So, very quickly, anything else that you'd like to add that we may have missed out on?
Can I tell you about a couple of events that are coming up?
Of course.
On the 21st of March, we have an event in the Central Library in Birmingham. That's a small conference being organised by a partnership, the Sickle Cell Society, UK Thalassemia Society, and the NHS screening programme. And it's basically about screening for thalassemia and sickle cell and the personal experiences of people who've been through the screening programme. So if there's anybody out there listening who has been through the screening programme, say in the last 5 years, who would be interested in attending, they can get in touch with us. Just email info at ukts.org and we can send you the details. Also, we have a family conference coming up on the 14th of April, which is in Leeds. And that's for anybody affected by thalassemia. Family members, friends, and also healthcare professionals are very welcome. Again, just email info at ukts.org and we can give you all the details. Both events are free.
I'd like to add one thing, if that's okay. I just wanted to talk a bit about what it's like to be a friend or family member to somebody who's got thalassemia, because we don't want to, as this discussion, we don't want to reach out to people who've got thalassemia. They often know a lot of the stuff that we've talked about, but you might have a friend at college, a mum in the playground, somebody at work who's got thalassemia. What can you do for them? And I think the simple answer is just be a friend or family member. You know, don't treat them any differently. They may want to confide in you, and if they do want to confide in you, they don't expect you to have all the answers. They've chosen you to confide in. That is flattering in itself, so just listen. But there's also another very practical thing that you can do as a friend or a family member, or just anybody who has found this discussion interesting. Donate blood. If you have thalassemia, the unit of blood that you receive is more likely to come from somebody from the same ethnic group as you, because we have to very precisely match each unit of blood. There is a lack of donors from the Black, Asian and minority ethnic group population, so the more donors that we can get from those ethnic groups, the better, and they will go directly to helping your community, your population, and every unit saves a life. It is as my friend Elaine and I were discussing earlier, it's a completely altruistic act. And as a blood donor myself, I cannot tell you how amazing the feeling is to know that you have donated a blood that has saved somebody's life. So that would be my final plea. If you want to do something for anybody affected by thalassemia, get out there and donate blood. It's really easy to find your local donation centre. And in Birmingham, we've got a massive centre in the centre of town, but they also go to smaller centres around Birmingham. So there'll be one near to you. So just look up the blood transfusion service.
So it's really important to think about all the times that somebody from our family members or friends or even ourselves may have needed transfusion that could have saved our lives.
Yeah.
And that came from somewhere.
Yeah.
So listeners, get out there, donate blood.
Yeah, do it.
So thank you for coming down.
Thank you.
It was really informative. Like any advice that we provide on Unity FM, we do tell you to speak to your doctor. This is just in general, but you need to get your specialist to answer questions specifically to you. Thank you very much. Goodbye. Today we're going to discuss topics relating to thalassemia and the effects and how it affects everybody. We've got two lovely guests from Sickle Cell Thalassemia Centre and Thalassemia Society.
My name's Liz Green. I'm the lead nurse at the Sickle Cell and Thalassemia Centre, which is the regional centre based at City Hospital in Birmingham.
Hello, I'm Elaine Miller and I'm from the UK Thalassemia Society, which is the only national charity which is set up to support families affected by thalassemia.
Right, so first of all, what is thalassemia?
Thalassemia is an inherited disorder of haemoglobin. Haemoglobin is a protein that's found in the red blood cell. Thalassemia causes problems with making enough haemoglobin, and the reason we need haemoglobin is it's a part of our red blood cells, and our red blood cells need to deliver oxygen all around our bodies.
So who carries thalassemia?
Well, basically, anybody can be a carrier of thalassemia. But if you're a carrier, it doesn't mean you're ill in any way. Carriers are just as healthy as anybody else. It's something that's within your DNA. And the problem arises with thalassemia if a man and a woman who are both carriers have a child together. Every time they have a child, there's a 25% risk that that child could have a clinical form of thalassemia and need medical treatment. So it's important that people are aware that anybody can be a carrier of thalassemia. It's much more common, however, in some communities. For example, anybody whose family origins are anywhere on the Indian subcontinent, they have a much higher risk of being a carrier of thalassemia. Anybody who comes from the Middle East and from certain parts of the Far East, it's a bit complicated to explain, but it's because there's a relation between malaria and thalassemia. But anybody who comes from those areas is at increased risk. The majority of people in the UK who are affected by thalassemia come from somewhere on the Indian subcontinent originally. And those people who are from those areas can get a test from their GP before they have children, which will tell them if they're carriers. That's really important, because if you know you're a carrier and there's a possibility that you might pass thalassemia on to your children, you can learn about it in advance. You can have, if you're going to get married, you can have your future wife or husband to take the test as well. And if they're clear, it's not a problem for you. Because as I said, it's only when a man and a woman who are both carriers have a child together that this problem can occur.
So are there different types of thalassemias, and how is that different?
Yeah, initially the two types of thalassemia that there are alpha and beta thalassemia. That sounds really complicated. Haemoglobin, which is that molecule that I said that is in the red blood cell, has two types of chains, alpha and beta. So the type of thalassemia that you have, whether it's alpha or beta thalassemia, just relates to which chains you don't make properly. In the main, our patient group has beta thalassemia, so the rest of this discussion will probably focus on beta thalassemia because that'll be what's relevant to most people listening. So that's the first differentiation. Then if you look at beta thalassemia, you'll hear people talk about beta thalassemia minor, beta thalassemia intermedia and beta thalassemia major. And there is a difference between these types of beta thalassemia. Firstly, beta thalassemia minor, this isn't a term that we use very much anymore because it gives the impression of an illness, albeit a minor one, where actually beta thalassemia minor is the trait status or the carrier status. As Elaine explained, if one parent just carries one beta thalassemia gene, they just carry it. They don't get any symptoms, they don't get unwell, but they just carry the disorder. So it isn't a form of illness, so generally we call that a carrier or trait status. If you have intermedia, this is a type of beta thalassemia that affects patients really differently. Some patients can go through life and not really have any illnesses or anything related to their intermediate thalassemia or need much treatment, but it is really important with beta thalassemia intermediate to get regular checkups from a doctor who understands thalassemia. This means a specialist doctor at a specialist centre. There might be one really close to you, or there might be one a bit further away, and so you can have joint care with your local hospital and a specialist centre. That can work really, really well. The key with thalassemia intermedia is to get monitored regularly. You may or may not require some blood transfusions during your life, and some people end up having regular transfusions, but the key with this type of beta thalassemia is regular monitoring. Beta thalassemia major means that you don't produce any functioning haemoglobin, so your red blood cells are not doing the job that they need to do, so you will need to have blood transfusions every month for the whole of your life. You will have these transfusions either in a medical day case unit or a haematology unit or a specialised thalassemia unit. And again, it is important that your care is overseen by a doctor who understands and specialises in thalassemia. Important to add with beta thalassemia major is that every unit of blood contains iron, so as well as regular transfusions, you'll need to take medications every day of your life to help your body get rid of this excess iron. It's the build-up of iron that can cause a lot of problems for people with beta thalassemia major.
Right, so of course to start with they would need to, because you said there's actually departments that they can visit, but do they need to start going to the GP first and then go to a specialist?
In this country, because of universal screening, so all babies who are born are identified as either having thalassemia or carrying thalassemia. There aren't many unknown thalassemics in this country because of the universal screening and because of parents being screened at pregnancy. So mom gets pregnant, if she didn't know her status, if they find out that she carries thalassemia, they'll automatically then test dad, so they'll know what's coming, if they've got a chance of having a baby with thalassemia. So generally unknown thalassemics don't crop up in this country because of the great universal screening programme. Those babies born will then, if they have tested positive for beta thalassemia, will have to start a blood transfusion programme really soon into their life.
So what about the people that we have moved over from a different country and they're not entirely sure if they have thalassemia or not?
The chances are they will probably know if they've got beta thalassemia major, because it's such a severe condition because your body can't function without functional haemoglobin, that they'll either know or suspect that something's not right. And beta thalassemia major, you are dependent on blood transfusion for life. Without blood transfusions, you wouldn't survive.
And if they're carriers?
Carriers, they probably wouldn't have noticed any ill effects. It would just be wise that if you're here in this country to find out your status, because it's good for when you're planning your children. If you've had your children and you're a carrier, in a way there's no need to know, but it might help you understand if your children need to be tested, if they're of marriageable and children age. Intermedia, there is a chance that people could end up in this country and not necessarily know that they've got beta thalassemia intermedia, because some people with intermedia have got through life with not really having much illness related or much treatment. So that scenario could happen. But you often hear that there are stories that of illness when they were back in their own country, so they did have some suspicions. Would you agree, Elaine?
Yes, I would say it's very, very unusual for anybody of any age to have a clinical form of thalassemia, i.e. intermediate or major, and not know about it. If you've got thalassemia major, basically you wouldn't survive to the age of 5 if you didn't have any medical treatment. So although, it's possible you might have somebody come into this country and they may not know the name of thalassemia, of what they've got, they'd know there was a problem. So, and as Liz said, babies are identified at birth by the screening programme if they've got a clinical form of thalassemia. And in this country, they're entered onto a pathway of care, so they'll be seen by a specialist doctor by the time they're 3 months old, and they're monitored very carefully then. The doctor will look very closely at their blood, and the doctor will decide when and if they need to start transfusions and any other treatment. So we're quite lucky in this country because we do have the screening programme and we do have the pathway into care for affected children. I'm not aware that the screening programme has missed any, completely missed any in 20 years. So, but back in the old days that did happen. Children would be born, and they'd seem fine at first because thalassemia doesn't affect the baby in the womb. It doesn't affect fetal hemoglobin. Just after birth, your body switches over from fetal hemoglobin to adult hemoglobin, which people with thalassemia can't make. So the baby would gradually, in the first year, start to get poorly, would stop feeding properly, not putting weight on, not thriving, probably picking up a lot of infections. And so amongst the older people with thalassemia, I'm talking about people who are now in their 50s, you will often hear them say that that's how they were diagnosed as a child, constantly going to the doctor, nobody realising what was wrong with them until eventually, somebody would send them to a hospital and they'd realise that they're actually terribly anemic and they needed blood transfusions. But that, as I say, that's the old days. Nowadays, everybody, there aren't any invisible thalassemia patients because they all, not major anyway, because they all go to hospital regularly for their transfusions.
Okay, so bringing up to the next question, what is the life expectancy of a child with beta thalassemia major?
Well, with the right treatment, there's no reason why they can't have a normal or near normal life expectancy, but it all depends on that crucial aspect of the treatment. Thalassemia, like a lot of other manageable long-term conditions, the health of the patient very much depends on the availability of the right medical treatment and the patient's the patient cooperating with the medical staff to make sure that the treatment's taken on time and in accordance with the medical advice. Other conditions are the same, like, for example, diabetes, which is more well-known than thalassemia. If somebody's insulin dependent, if they didn't take insulin, it would be fatal in most cases. So, and thalassemia is the same. It's manageable, but it's manageable with the right care. We're very lucky, again, in this country. We've got some of the best doctors and medical and nursing staff for this kind of condition in the world. So the right care is available. It's very challenging, obviously, as a patient. If you've got to, as Liz said earlier, if you're having a blood transfusion every 3 or 4 weeks throughout your life from babyhood onwards, that sounds very challenging to anybody. And when people who aren't familiar with thalassemia hear that, they normally go, "No way, a transfusion every 4 weeks." It sounds terrible, but for people with thalassemia, I'm not saying it's nothing, but they are used to it. They're used to that aspect of their treatment because that's what they've always known. There are other aspects to their treatment. The medication to get rid of the iron overload, which Liz mentioned earlier, which again is a very challenging treatment very often. And that's something that everybody has to work out for themselves with their doctor, and stick to that treatment.
Yeah, I would agree, because for people who don't have an experience of a condition like thalassemia or any other chronic illness, to hear that all the treatments available in this country for you to live a long life, it must sound ridiculous that some people don't take all their treatments. Why would you not take all your treatments? And the answer to that isn't simple. It's hard work to take medication every day, particularly when you're a child, and then when you're a teenager and a young adult. It's really hard work to take medications every day that you don't see any particular effect from. They're just preventative. We all find it easy to take a paracetamol to cure a headache because it's a medication that we take and it has an instant effect. But we need our patients to take medications every single day of their life to prevent them getting problems when they're older adults. And that is the really challenging part of, as Elaine says, lots of other chronic illnesses, but the really challenging part of thalassemia. But the good news is, if you manage to take your medications and you have your transfusions, there's no reason why you can't do anything you want to do with your life and live as long as you want to live.
So what is the typical medical care involved for a person with thalassemia or any kind of thalassemia?
Well, I think we've just sort of covered that, really. If you've got beta thalassemia major, you'll need to have 3 to 4 weekly transfusions for life. Mm-hmm. So that often involves a trip to the hospital to get your blood test, and then a trip to the hospital the next day or the day after to have your transfusions. And you might have your transfusions at a medical day case unit or a haematology unit with other people with all sorts of different conditions, or you might go to a specialist unit that just focuses on sickle cell and thalassemia. Any of those is fine. We also would expect you to have regular visits to see your specialist doctor. And like we say, in areas where there isn't a specialist centre, you could have local follow-up and go see a local doctor and then go and see your specialist doctor who might be further away. We expect people to take medication every day. Patients with thalassemia are also at risk of infections more than people without thalassemia. So we'd also like people to just take a few more preventative measures to prevent infections, and just follow a good healthy lifestyle like we all do, don't we, Elaine?
We're meant to.
And I guess that would be the same for somebody with intermediate thalassemia as well, because
thank you for reminding me.
Yeah, because like you said, they don't always have the same sort of symptoms, and they don't come at the same time. And
that's thank you for reminding me about intermediate, because sometimes that can be the harder one to manage, because our patients with beta thalassemia have to come for a transfusion every 3 to 4 weeks, otherwise they feel terrible. And so it's easy then to slot in your doctor's appointment around that, whereas somebody with thalassemia intermediate might be feeling okay and so just get on with life, but actually they really need to be monitored regularly, and regularly will be what they decide with their doctor. But somebody just needs to keep an eye, and they might not need any treatment, but they just need regular monitoring, regular checkups from a specialist doctor. It's also worth saying at this point, your specialist doctor is specialist in thalassemia. They don't know about everything. There can be a tendency to think that your thalassemia specialists know everything about everything, but you still need your GP as well. We have to work alongside GPs, because GPs are still best at all the general stuff.
Right, so explain like a typical meaning, what is a daily living with a person or a child with thalassemia?
Well,
could be
a lot of it is going to be similar to that of any other child. Mm-hmm. But typically, if a child who's got thalassemia, they're probably on some kind of medication that they might have to take before they go to school. So for their parents, it can be a bit of a challenge, because sometimes it can give you a bit of an upset tummy. It can take them longer to eat than other children because of this. They go to school normally. They do all the things that other children do. There's no reason why they can't do games and sports. Sometimes if a child's got thalassemia major, in the week leading up to their transfusion, their hemoglobin level is going to be dropping a little bit, so they may feel a little bit more tired than they normally would. What we would always advise to teachers and games teachers and any other teachers is not to, if they say they feel too tired to do an activity, don't force them to do it, but give them the opportunity to do it. And there's certainly no reason for them to be prevented from going on school trips or outings or anything of that nature. They should just be treated like any other child, basically. For their parents, obviously, they've got the challenge of taking them to hospital for their appointments and for their transfusions. And unfortunately, that can mean time away from school. That can be difficult when they're getting a bit older and they're getting ready to take exams that are important, because unfortunately one thing that we don't have in many hospitals is the facility to have transfusions in the evenings or weekends. So it can mean time away from school or obviously away from work if you're an older person. And that is one of the major challenges that people with thalassemia face. As I said, leading up to transfusion, they may feel a little bit more tired than normal. And then after they've had their transfusion, their blood levels are boosted up again and they probably feel a great deal better. But I think if you're a parent who's got a child with thalassemia, like any long-term condition, it is challenging because you have got a lot of work to monitor that child and make sure at the same time that you're treating them exactly the same as their siblings if they've got any, because it's very tempting as a parent when you've got a child with a diagnosed condition like this to sort of wrap them up in cotton wool a bit and to treat them much more gently than you would other children. But we would say to try and not do that, because the older people that we all know that have got thalassemia, the ones who've done best, who've got very active and full lives as adults, they will all say, when I was a child, my mum and dad just made me get on with it. If I said I don't want to go to school, my mum would say, rubbish, you're going, get up. I was pushed to do as much as I possibly could. So it can seem difficult for other family members to understand sometimes. They will say, can't you give him a break? He's got this condition. But really the parents, if they're pushing their child to... I'm not saying that they should, if they're really sick, obviously, but they should just encourage them to do all the things that any other child would do. There's nothing wrong with them. Their intellect is completely unimpaired. They can learn just like anybody else can learn. And we have people with thalassemia major in every profession you can think of. I know one chap who's a judge. We have barristers, we have teachers, we have doctors and nurses. We have people running their own businesses. We've even had a couple of criminals.
Of course, like anything.
So they didn't hold them back.
Absolutely not. So like any other condition, any other person, people with thalassemia are extremely capable. And often I think the fact that they're facing these daily challenges in their lives gives them a kind of resilience and determination, and it can make them. Some of them can use it as a positive if they're going for job interviews, and they can talk about the way they manage their condition as an example of good time management and efficiency, etc., and turn it into a positive rather than a negative. There's no reason why a person with thalassemia in this country in this day and age should feel limited. They're probably not going to be a professional athlete, because they have got a medical condition. But, in other terms, in terms of their intellect and their capabilities, there's no need for them to feel limited at all.
I would agree. And when we talk to some of our older patients who've gone on to live really full and successful lives, and ask them what tips they'd give and how they got to where they are, a lot of them talk about their parents and the way that their parents kind of would not let thalassemia get in the way, that they still had to go on and do what they wanted to do. They were allowed the same hopes, goals and desires as every other member of their family, and that would be the advice that they would give to parents who've got children with thalassaemia and children themselves with thalassaemia. Just go for it.
One thing you've mentioned about unfortunately not having the facilities in the evenings or weekends. I think, if I'm correct, SCAT Centre just recently started doing Saturday services as well, which is like a normal open day.
Yeah, so we were really lucky. So SCAT is the Sickle Cell and Thalassaemia Centre, and we were really lucky to be able to start opening on a Saturday. And it took a long time to get to that, but it's been really successful. It's not full, and initially patients were very much, oh no, I'll come in the week, but it's becoming increasingly more popular, and especially for our new patients moving up from children's services, it can be a good way of not letting it get in the way of their education or a new job, or so it can be really popular, the Saturday service. We looked at whether we did evenings or whether we did Saturday, and in the end we went with a Saturday because that was what the patients voted as they thought they'd want more.
Plus, that way, if somebody was working full time and they had a day off in the week, they could come in, have a cross match, and then have the transfusion on the Saturday, or vice versa. Yeah. So it might be worth to kind of look at your local centres and to see if they have anything similar.
And certainly, it's something that we should all be striving for. So if it doesn't happen in your local area, tell somebody that you want it to happen, because we only did it because people wanted it. You know, we don't set up a service because people don't want it. You know, if people want it, then we can, not always, but we can look at setting it up.
Right. We're just going to take a short break and get back to you as soon as